imagine this for a second. You're a horse owner, right? And your partner, your horse, starts showing this subtle lameness. It's kind of nagging. At first, maybe it's just off and on, a bit stiff on hard ground, maybe a stumble here and there. But it gets worse, and you just can't figure out why. It's so frustrating.
Yep.
A real mystery. Well, today we are diving deep into one of those really complex, often kind of misunderstood conditions, navicular syndrome. You might have heard it called other things too, like caudal heel pain or podotrochleosis. Is that right?
That's it, podotrochleosis. And, right off the bat, it's really important to clarify that navicular syndrome isn't like one single disease. It's actually a complex syndrome, basically a collection of signs that covers pain coming from several different structures right there in the horse's heel. We call this whole area the navicular apparatus. And the key players, the main parts, are the navicular bone itself. It's small, kind of boat-shaped. Then there's the navicular bursa, which is like a little fluid-filled cushion. The big, deep digital flexor tendon.
Yeah.
The DDFT, and then several important ligaments holding it all together.
Okay, wow. So lots of moving parts in a small area.
Okay.
Let's unpack this then. Our mission today is to really get into the nitty-gritty of navicular syndrome. We want to help you, listening in, really grasp what causes it, how vets actually figure it out, pinpoint the problem, and this is crucial, what the long-term management looks like. We're aiming to turn this potentially overwhelming info into something clear, something you can actually use.
Exactly. And maybe the best place to start is breaking down each part of that navicular apparatus you mentioned. So the navicular bone, we also call it the distal sesamoid bone. It's this small bone tucked right behind the coffin joint, deep inside the hoof.
Right, deep inside.
Then there's a navicular bursa. Think of it like a tiny fluid-filled sac. Its whole job is to provide a smooth, cushioned surface, almost like a little shock absorber between the navicular bone and that really powerful deep digital flexor tendon, the DDFT. This big tendon runs down the back of the leg, slides right over the navicular bone, and then attaches to the coffin bone, the very last bone in the foot. And finally, you've got these vital ligaments. They provide stability, like crucial little guy wires, holding everything exactly where it needs to be.
Okay, you've painted a really clear picture of this, finely tuned machine back there. With all those intricate parts, what's the usual suspect? Where does the pain typically start when things go wrong?
Yeah, that's a key point. The problem usually stems from degeneration. Degeneration of the navicular bone itself and the structures right around it. This happens because of abnormal forces, chronic stress, concentrated in that heel area over time.
Ah, so it's like wear and tear.
Exactly. You could think of it a bit like osteoarthritis or other degenerative joint diseases we see in people. It's rarely just one thing, one sudden event. It's usually multifactorial, long-term biomechanical stress, maybe conformation issues, other factors piling up.
I can see how that constant force would just build up. It's almost like a slow burn problem. Are there certain types of horses or maybe certain signs that should make an owner think, maybe I should look into this, even before it's really obvious lameness?
Oh, absolutely.
Yeah.
When we look at who's most at risk, navicular syndrome tends to hit middle-aged horses the most. And interestingly, some breeds pop up way more often. We see it a lot in quarter horses, thoroughbreds, and warm bloods.
Really? Quarter horses and thoroughbreds?
Yeah. But on the other hand, it's actually quite rare in ponies, donkeys, mules, and Arabians. And several things can contribute to those abnormal forces we talked about. Faulty conformation of the lower leg, hoof balance issues. The classic one is long toe, low heel, but also just excessive toe length, or heels that run forward, what we call underrun heels.
Right, the conformation.
Horseshoeing plays a big role too. Lack of heel support. Sometimes even just a big-bodied horse with relatively small feet. Or maybe mismatched front feet, doing a lot of work on hard ground. All that can contribute. As for those early signs owners might spot, often it starts as this intermittent lameness, kind of comes and goes, but slowly gets worse. It's very commonly worse on hard surfaces, or going up or down hills, or when the horse has worked in tight circles, especially with the sore leg on the inside.
Ah, the inside leg on a circle. Makes sense.
And while one leg might seem worse, it's very often affecting both front limbs. Bilateral lameness is common. You might see this characteristic short, choppy stride. Sometimes people call it a shuffling gait. The horse might stumble more or just seem reluctant to work. And a really big clue for owners is when the horse tends to point the sore foot at rest, just holds it slightly out in front.
Ah, yes, the pointing. I've seen that.
Sometimes you might even notice they seem more lame right after they've been shod.
And if a vet comes out, what might they find during the actual hands-on exam, besides watching the horse move?
Well, during the physical, we often confirm that long toe-low heel shape if it's there. Sometimes you can feel heat in the hoof capsule itself, or maybe stronger digital pulses, the blood flow to the foot. A key finding, though, can be a pain response when we use hoof testers, specifically pressing over the frog area or the heels.
Okay.
You might also notice the frog looks a bit shrunken, atrophied.
Gotcha. So the signs can be pretty subtle, especially early on, and the causes are tangled up. This really drives home why you need a systematic way to diagnose it. How do vets play detective here, trying to pinpoint something hidden deep inside the hoof? What are the main tools you use?
Exactly. Diagnosis has to be precise. We start with that clinical exam, watching the horse move, using the hoof testers like we just mentioned. Another really important part is the distal limb flexion test. We hold the lower leg flexed fetlock and coffin joints for maybe a minute, then have the horse trot off immediately. If the lameness gets significantly worse right after that flexion, it strongly suggests the pain is coming from those lower joints or structures.
Okay, so that helps narrow it down.
But probably the most crucial diagnostic step, the real game changer for confirming the pain is actually in the foot, is diagnostic anesthesia. Nerve blocks. The palmar digital nerve block, or PDMB, is usually the first one. We inject local anesthetic around the main nerves at the back of the pastern. This numbs the entire back half of the foot, of the heel region. If a horse was, say, grade 2 lame, and after that block it's suddenly 80% or even 90% sound,
Wow.
that tells us very strongly the pain is coming from that heel area.
That's pretty definitive then.
It's a huge piece of the puzzle.
Oh.
For even more specific localization, we might then do an intra-articular coffin joint block, injecting anesthetic right into the coffin joint, or an intrabursal navicular block, injecting into the navicular bursa itself, usually using ultrasound guidance for that one.
So the blocks tell you where the pain switch is, but to really understand why it hurts, you need to see inside, right? How do you get that visual story?
Exactly. Imaging is where we get to see what's actually going on structurally. Radiography or x-rays are almost always the first step. We take several standard views, and one called the skyline view of the navicular bone is absolutely essential. It gives us a unique angle to see changes on the bone surface where the tendon runs.
Skyline view, okay. What kind of things are you looking for on these x-rays?
We're looking for signs of how the bone has reacted to that chronic stress. Things like small cyst-like lesions within the bone or changes in bone density. Sometimes it gets denser, sclerotic. We might see little bony spurs where ligaments attach, what we call enthesophytes. Or maybe erosions on the surface where the DDFT glides. Sometimes even little fragments broken off the edge. We also look at the channels where blood vessels enter the bone. Sometimes they look enlarged, like little lollipops.
Lollipop lesions.
Interesting.
But here's the kicker, and this is really important for listeners to understand. Finding some of these radiographic changes is actually pretty common, even in horses that are perfectly sound.
Yes. So a vet can't just look at an x-ray by itself and say, yup, navicular syndrome. Those x-ray findings have to be interpreted together with the clinical signs, the lameness, the pointing, and crucially, the results of those nerve blocks.
That's a critical distinction. You could have an x-ray that looks a bit iffy, but the horse feels fine. So if x-rays give part of the picture, what's the gold standard for really seeing everything, especially the soft tissues, the tendons, the ligaments?
That would absolutely be magnetic resonance imaging, or MRI. It is, hands down, the gold standard for soft tissue imaging inside the hoof.
Why MRI? What makes it so much better for this?
Well, the hoof wall itself blocks ultrasound waves, so we can't get a really good, complete look at structures like the DDFT or the navicular bursa with ultrasound once they're inside the foot. MRI uses powerful magnets and radio waves to create incredibly detailed slice-by-slice images. It can show us things like tears or adhesions in the deep digital flexor tendon, problems in those collateral or distal impart ligaments, inflammation inside the navicular bursa. Even subtle things like bone marrow edema, like bruising within the bone, that just don't show up on x-rays at all.
Wow.
So the benefit is huge. It often confirms the diagnosis. It helps guide very specific treatments like should we inject the bursa or the joint. And it gives us a much more accurate prognosis, a better idea of the horse's chances.
Are there downsides to MRI?
The main limitations are cost. It's significantly more expensive than x-rays. It requires general anesthesia, which always carries some risk, and availability. Not every clinic has an MRI machine.
Okay. Are there other imaging tools sometimes used?
Yes, a few others. Nuclear scintigraphy, or a bone scan, can be useful. The horse gets injected with a radioactive tracer that collects in areas of active bone turnover or inflammation. It creates images showing hot spots. It's very sensitive, good at picking up problems early, but it's not very specific. It tells us there's inflammation in the heel, but not precisely what structure is inflamed.
So sensitive but not specific. Got it.
CT scans are another option, computed tomography. It's excellent for looking at bone in really fine 3D detail, even better than X-rays in some ways, but it's not as good as MRI for evaluating the soft tissues. And then, much less commonly, there's navicular bursoscopy. This is actually a surgical procedure using a small camera inserted into the navicular bursa. It allows direct visualization and sometimes treatment right there, but it's invasive.
Right, surgery itself. Okay, so the vets have done their detective work, used these amazing tools, and they've pinpointed the problem.
Yeah.
Now comes the hard part, right? The management. You mentioned earlier there's no single cure. So what does that long-term, multi-pronged approach actually involve? How do you manage this?
You're absolutely right. No quick fixes here. Treatment is always a long-term game plan, usually involving multiple things at once. And it's all aimed at managing the pain and trying to slow down the degeneration. And arguably, the most critical piece of the management puzzle is corrective farrier, good hoof care, and shoeing.
Okay, so the farrier is key.
Absolutely essential. The main goals with shoeing are to restore proper hoof balance, take stress off that navicular apparatus in the heel, and make it easier for the foot to break over, to roll forward and leave the ground smoothly.
How do they do that? What kind of shoeing changes help?
Well, common principles include shortening the toe that reduces leverage on the front of the foot, and importantly, raising the heel.
Raising the heel.
Yes, often using wedge pads or special wedge shoes. Raising the heel slightly reduces the tension on that deep digital flexor tendon as it runs over the navicular bone. We also want to support the back part of the hoof, the caudal hoof. So using bar shoes, like an egg bar shoe that's oval, or a straight bar shoe across the heels, helps provide more support and distribute weight better.
Makes sense, changing the mechanics.
Optimizing breakover is also key, maybe by rolling or rockering the toe of the shoe, but it really requires close teamwork and communication between the veterinarian and an experienced farrier who understands these principles. It has to be tailored to the individual horse's foot.
Okay, so shoeing is foundation number one. What about the medical side? What medications or therapies can vets bring to the table?
Medically, we have options that work systemically throughout the body and locally right at the site of pain. NSAIDs, non-steroidal anti-inflammatory drugs, are very common. Things like phenylbutazone or Bute, or maybe furacoxib, which is Equox. These are given orally, usually to help manage pain and inflammation.
Standard anti-inflammatory.
Right. But the caveat is, especially with long-term use like we often need here, we have to be mindful of potential side effects, gastric ulcers, kidney issues, so monitoring is important. For more targeted relief, intra-articular injections are frequently used. Injecting corticosteroids, powerful anti-inflammatories, directly into the coffin joint can help a lot. Sometimes we inject the navicular bursa too, usually with ultrasound guidance. Hyaluronic acid, or HA, might also be injected into the joint.
Direct injections. And what about some of the newer, maybe more advanced stuff we hear about, like regenerative therapies?
Yes, absolutely. We're increasingly using biological and regenerative therapies. Things like IROP, which stands for interleukin-1 receptor antagonist protein, or ACS, autologous conditioned serum, also PRP, platelet-rich plasma, and stem cell therapy. The idea behind these is to use the body's own healing factors to reduce inflammation and potentially encourage some tissue repair. There's also a synthetic option, polyacrylamide hydrogel, that's sometimes used.
Interesting. Lots of acronyms there.
Huh. Yes, veterinary medicine loves its acronyms. And then there's another class of drugs called bisphosphonates. Osphos or Tildren are the common ones. These drugs work by slowing down bone resorption, the process where bone is broken down. By doing that, they can help reduce bone pain and inflammation, specifically coming from the navicular bone itself.
So they target the bone pain directly.
Exactly. One important note, though, is they shouldn't be used in horses that already have kidney problems.
Got it. So it's a combination of hoof mechanics, anti-inflammatories, maybe these biologics, bone agents. What about just basic rest and exercise modification?
Crucial. An initial period of rest is often needed, especially when things first flare up or after treatments like injections. But then it's usually about a gradual, controlled return to exercise. The key is working on soft, forgiving surfaces, avoiding hard ground, avoiding deep footing, avoiding sharp turns or tight circles, anything that puts extra strain on the heel.
Soft footing is key. Any other therapies people try, like lasers or shockwave?
Yes, those are what we might call adjunct therapies. Things like therapeutic lasers, extracorporeal shockwave therapy, ESWT, and PEMF, which is pulsed electromagnetic field therapy. These can sometimes be helpful additions to the plan, mainly for reducing inflammation and potentially promoting healing in certain cases.
Mm.
They're usually used alongside the core treatments like shoeing and medical management.
Okay. And what if none of that works or stops working? Is surgery ever an option? You mentioned bursoscopy earlier for diagnosis.
Well, bursoscopy can sometimes be therapeutic too, like cleaning out inflammation. But the main surgical intervention discussed for navicular syndrome, usually considered a last resort, is palmar digital neurectomy.
Commonly called nerving.
Exactly, nerving. This involves surgically cutting those palmar digital nerves we talked about blocking earlier. The goal is to permanently desensitize the back part of the foot, the heel.
So it stops the pain signal.
It eliminates the pain, yes, but, and this is incredibly important, it does absolutely nothing to fix the underlying problem. The degeneration, the tendon damage, whatever is actually wrong is still there. The horse just can't feel it anymore.
That sounds risky.
It carries significant risks and ethical considerations. One major risk is neuroma formation. Painful nerve stump tumors can grow where the nerve was cut. Sometimes the nerve function can even return over time, called reinnervation. But maybe the biggest concern is the risk of catastrophic injury to the numb foot. Because the horse has no pain sensation, they can get a deep puncture wound, a bad abscess, or even rupture their DDFT and not show any lameness until it's too late.
Oh, wow. They wouldn't even limp.
Not necessarily, or not until the damage is severe. It's why horses that have been nerved are often ineligible for many competitive disciplines. It's a big decision with serious potential downsides.
Yeah, that's a huge trade-off, just masking the pain without fixing the cause. Okay, so given this whole complex picture, the diagnostics, the multimodal management, the potential risks of surgery, what's the realistic long-term outlook? What's the prognosis typically like for a horse diagnosed with navicular syndrome?
Generally speaking, the prognosis is usually described as guarded to fair. It's honestly rarely considered excellent for a full return to previous levels of athletic performance without restrictions, especially if the condition is severe or it's been going on for a long time. And it's worth repeating. There is no cure. It's a degenerative condition. Our goal is always managing it, effectively managing pain, maintaining function as much as possible.
Guarded to fair, that sounds okay, but not great.
It's highly variable, though. The prognosis really depends on a lot of factors. Which specific structures are involved? How bad are the lesions we see, say, on an MRI? A small bit of bursitis is very different from a big tear in the DDFT. How long has the horse been lame? What's the horse's age and intended job? And critically, how committed and compliant is the owner with the recommended long-term management plan? That's huge.
Right, the owner's role. But it does sound like, despite the challenges, maybe many horses can still have a good quality of life, even if their job changes.
Oh, absolutely. Many horses can be successfully managed to stay comfortable and productive. It might mean stepping down a level competitively, or changing disciplines, or maybe becoming a pleasure horse, or even just a comfortable pasture companion. Consistent, appropriate veterinary care, and especially farrier care, makes a massive difference.
So what factors might point towards a better prognosis versus a poorer one?
Well, a better prognosis is generally associated with things like an earlier diagnosis, when the changes are milder. Maybe it's primarily soft tissue inflammation that responds well to treatment, rather than severe bony changes or tendon tears. A good initial response to conservative management, like if corrective shoeing and maybe some joint injections, make a big difference. And like I said, excellent owner compliance with the long-term plan.
And the flip side, what makes the outlook worse?
A poor prognosis often comes with severe, long-standing lameness before diagnosis. Significant structural damage seen on MRI, like major DDFT tears or bad bone cysts. A failure to respond well to multiple conservative therapies. Or, unfortunately, the development of those painful neuromas after a neurectomy surgery.
That really drives home just how crucial that team approach is, doesn't it? It's not just the vet, not just the farrier, not just the owner. It's everyone working together, communicating, tailoring the plan for that specific horse. It really sounds like a partnership.
Indeed. It absolutely is. That collaborative effort is what gives the horse the best shot at comfort and continued soundness, whatever that looks like for them.
Well, we've certainly taken a deep dive into navicular syndrome today. It's clear it's a really complex and often challenging condition for everyone involved. But I think what's also clear is that having an informed understanding, knowing the options, and embracing that multifaceted approach really offers the best path forward for these horses.
I agree. And what's compelling, I think, is that, while it is challenging, our diagnostic tools, especially with MRI, getting better and more accessible, and the sheer number of therapeutic options we now have compared to, say, 20 years ago,
Hmm.
it offers significant hope. We can do a lot more now to manage pain effectively and really improve a horse's quality of life, even with this diagnosis.
That's a positive note to end on. So, thinking ahead, given these constant advancements we see in vet med, particularly in imaging and these biological therapies, what do you think might be the next big thing for conditions like navicular syndrome? Are we getting closer to moving beyond just management? Could we eventually see truly regenerative cures? And maybe stepping back, what broader lessons does this whole journey, understanding the biomechanics, the degeneration, the management, teach us about tackling complex degenerative conditions, really in any living system?